Pleasure to follow Todd and Chris today because I will need their help on lots of things in terms of impact and finding other sources of funding, packaging for dissemination and upscale. So this is what I've been working on for many, many years. So again, a pleasure to speak with you all today about the WeCarePlus program that has been focused now for 3.5+ years on impacting risk factors for infant mortality and outcomes, most recently in central Indiana. I have no disclosures, but I have a lot of acknowledgments. We have folks in terms of creative sources of funding through a variety of grants, internal and philanthropic, for the WeCare program over the last several years. Began with an IU Health grant, a values grant, but we had the Simon Cancer Center provide additional resources for the smoking cessation portion. We had the Indiana Hunger Network throw in another $100,000. We've had additional extensions of the project through Fairbanks Foundation for our women with substance abuse disorder, and then the IU Grand Challenge Addictions Initiative, and of course then our base here at Regenstrief, all helping support this project. So thank you to all of those folks and the State Department of Health. So this all began, and some of these slides, forgive me, are redundant to prior presentations, but just for anchoring those that are new, particularly our new interns who are here this summer. Welcome to all of you. This program and research arose from a call several years ago from IU Health Values Grant to address the needs of the state of Indiana based on their community needs assessment that they do periodically as part of their the values and missions of the institution. Many needs arose as some of the top priorities for the state, including infant mortality. We've improved a little bit in the years since then. We're now only the 9th worst instead of the 7th worst. Still tremendous regional variations in health disparities. Among the list of problems that the state of Indiana face: obesity, smoking, mental health. And all of those in reality are bundled together, contribute directly or indirectly to infant mortality. So we ended up taking it on as a kind of a holistic challenge under the rubric of infant mortality as a complex intervention package. Again, just to kind of context this, in 2017, the most recent stats we have, infant mortality is measured in 1,000 births. For the US, it's 5.8. For Indiana, most recently 7.3. Health disparities, 2.6 times the risk for African American infants than white. And here in central region, we have about close to 1/3 of the deaths right here of the 600, which is about, every 12 hours, they say a baby dies. So it's a big problem. There are certain zip codes that have been carefully characterized. There are 6 of them. This is not the most recent data. They do two-year cycles, but I didn't update that. But essentially, the zip codes remain very similar with the 6 highest risk zip codes right here in central Indiana, many of them in Marion County. And again, of those same 6 zip codes, you can see the data here showing 2 to 3 to more times risk for African American infants in those regions. So the WeCare program went forward as a implementation science project focused on 5 basic risk factors: 3 for maternal risk, 2 for infant. The maternal ones were smoking, substance abuse, and mental health, kind of bundled together as a big packet of concerns. Obesity, which really ended up being a proxy for food insecurity and other concerns of the population we were serving and studying. Infant health was safe sleep and breastfeeding. So again, we started with the project team. We need to get my glasses here. We had our health analytics core, which was really a key group embedded here in Regenstrief are health data core under Anna Roberts, and others have been instrumental in the measurement side of this, where we can truly say we have now an academic and community partnership. We started with 2 different counties in Marion County and Delaware initially. Both federally qualified health centers got community action teams together that included critical members of the community, including community agencies, community action team coordinators, community members, et cetera, to give it really an emergent design, patient-centered, community-centered. The 2 sites we began at were Raphael Health Center and Open Door, again in the respective communities, working together, developed the training materials, the educational materials, and a whole set of mHealth educational messages that went out through an internally designed SMS platform. We then went ahead and hired community health workers, which are the critical effector arm of our intervention. And this is based again on evidence around the world that community health workers can be very effective in taking evidence and implementing it in their community and studying what is and isn't effective as we try to export models of care that have evidence behind them and put them to work. We had many collaborators, both academic and community, all of those listed there. So it was not done in isolation. It was highly collaborative, highly open to many partners. And then we had a program manager who took on the hard job of corralling us all. The funding initially, as I said, came through the IU Health Values Grant, but about a year into this, we had the opportunity to apply for one of the State Department of Health Safety Pin grants. We asked for 2.4 million, we were given 2.1 million, and were allowed then to upscale in central Indiana, but not in the eastern region where we had hoped to do an upscaling in both. And we then added many members, federally qualified health centers through Eskenazi Health Net clinics, continue to work with Shepherd Community Health Center and Raphael Health Center. The way the funding was, we had to show of the 10 awardees that there was an impact within 2 years of the state accumulated figures for infant mortality, or we wouldn't get the final 2 years of funding. So in 2017, for the central region where we upscaled, you can see that the numbers went down from the 2016 values from 7.4 to 6.6. Again, just for the central region. So that was the sole measure of our success or failure from the state departments of health to allow us to move forward, even though we were really working with a small microcosm of the group. So I had gone in presuming this would be an impossible challenge, but one worth working toward, and that if we didn't move the mark, we would look for alternative funding. Fortunately, we were able to get the additional funding, and because others who had not been successful in meeting their goals working in different regions, they opened up a competitive process for applying for those funds, and we received, in addition to the 2-year carry-on funding, an additional $1 million to upscale. So we were able then to move our sites from the few we were working with at Eskenazi and HealthNet to expand to the 9 centers, community health centers, federally qualified health centers of Eskenazi, and up to 5 centers through the HealthNet system. We are working in the 6 top risk codes, as I mentioned earlier, that are the absolute highest for infant mortality, and then the next 7. So the top 13 zip codes in central Indiana are where our community health workers work and are deployed. This was courtesy of Sarah Roth, some heat maps that we've been looking at to better define the population we're serving. Just to give you a sense of the challenges that are faced by the women and fathers of babies in these areas. So these are the 13 zip codes. Unemployment, overlapping these zip codes. Homes with no vehicles, overlapping our zip codes. Food deserts, overlapping our zip codes. Bus lines that may or may not get people where they need to go, and even if they can afford a bus pass. So there are many more. There's crime, there's violent crime, there's others. I could show you many heat maps, and they're much more interesting, interactive online. But these are where our women are living, and the group that we are serving. So again, the key elements of the intervention, evidence-based, that we adopted to implement and study were the health coaching delivered by our community health workers who came from the local communities. Again, a model that's used across the world, including in the United States. Tailored messaging, we know that being able to augment educational messaging just in time that's both tailored and targeted. Once you do screening and risk identification for these women can be helpful when a coach can only meet with somebody every so often in their home or at the clinic or even through the through texting or other forms of contact. And then we added fathers and first responders to help get us outside of the existing health care centers to identify even the highest risk women who never come in for their antenatal care and so forth. Again, this is just a really quick little overview of the hiring process that we think is very critical. We've published this process in other studies where we've employed community health workers as the most important effector arm of our interventions. And we found that these multiple mini interview stations, just like they've used for health professions students where they're trying to get individuals with competencies that they can demonstrate rather than just talk about how caring and compassionate they are. They show it in these stations. This is just, it's hard to read, but a lot of detail, but the crux of it is that we've identified areas of competence where the candidates need to go through stations and are then co-challenged, co-interviewed, co-reviewed by one of the folks on our staff, as well as an existing community health worker. And at the end of that, they all fill out scales on things like handling challenging emotional issues, building rapport, empathy, handling negative emotions, that sort of thing that is really hard to judge a candidate on just through the usual HR processes. These are 4 of our community health workers that work at Eskenazi. We just went through a multiple mini interview station yesterday or the day before and have 2 new candidates that will be offering positions for Eskenazi as part of our upscale. Again, these individuals who we hire are trained by Wilma Griffin, our trainer for WeCare, as well as other members of the team, but that's again, a model where we know community health workers are lay workers. They have no formal education other than a GED or high school degree, and then have those characteristic empathic caring skills that we are screening for. So we supply them with all of the content and resources needed to connect the women in our study to all the necessary resources. But that's not one and you're done kind of training. We have sent several of our staff to New Mexico for ECHO training at the ECHO Institute, which is a platform used across the world for helping with training and dissemination of care with supervised practice through weekly, in our case, weekly case conferences. So you'll see one of our rooms that's used every week to dial in using the Hollywood Squares to all of our community health workers out in the community on their mobile offices or mobile phones to dial in. And they bring the cases forward, their challenges, their victories, and those are staffed each week. We also have ongoing CEU, again, to try to keep them current on topics that were covered maybe initially. Here's one of the speakers on breastfeeding from the Breastfeeding Coalition, giving a CEU kind of in-service. So they're well supported is the message behind that, and ongoing education, intervention support, again, with lots of reinforcement that they're not an expert. They're really there to understand the resources in the community and connect. And then the SMS platform took many years to develop and establish so that all of the coaches are trained to sign the women up based on their own self-expressed interest and identified prevalence in the screening on any one of the topics. We enroll pregnant, postpartum, and women between pregnancies. So there's primary campaigns in those areas as well as sub-campaigns in any of the variety of risk factors. On average, there's about 20 messages per campaign, but it's programmed such that the women who are interested, no matter how many of these they elect to sign up for, will not get more than 2 messages a day on their phone. Again, just reinforcement booster. The community health workers are frontline again in both the delivery of care and also in the tracking of care. We have standardized checklists. We train them. Anna Roberts and her team have helped, and Rachel Gruber, build the REDCap databases. We use validated tools wherever possible, including the PHQ-2 and the GADs as screeners, and then the 9 and the 7 as appropriate. So just to give you a sense of the kind of tools that are programmed and the kind of data collected at intake and then routinely across the duration of the intervention. We have lots of process measures that we parallel the 5 primary pillars, if you will, smoking, depression, nutrition, et cetera, as well as kind of dose intervention effects, messaging, and coaching. So who are our patients? I've mentioned that we have been recruiting primarily pregnant women, 86%. So this is as of the end of December, which was the end of some of the first 2-year cycles of our funding. We have the women of childbearing age that range from 13-year-olds to 35-year-olds. We have worked predominantly in our high-risk zip codes, so again, 56% African American. We have a Hispanic slice of folks enrolled, white and other, but predominantly African American or biracial. In terms of dose, this gives you a little sense of the amount of messaging going out. We've had the primary campaigns, pregnancy, postpartum, other, as well as tailored. Over 16,000 have gone out to the phones of these women, which was no small feat since their phones go on and off and re-enrolling and this and that. But they are being used. People are electively enrolling in those. So outcomes, process, behavioral and otherwise. We have had Kyle Linville work with us for now going on a year to help us look at all of the data coded, looking at both the prevalence of our pillar risk factors as well as change scores. So, simple look at improved behavior, looking at change from baseline to current. We have seen improvements in all areas. 4% smoking, 6 substance abuse, mental health changes improved, nutrition, some improvement of skipped meals, WIC. 80% enrolled of those who are WIC eligible, which is really important for sustainability of food insecurity. And then the safe sleep practices improved in key areas of sleeping on back or sleeping alone. The substance abuse area here, when we revealed that 13 to 18% of our women were self-reporting substance abuse, we knew we had a major concern. And that is about the time that the IU Grand Challenge initiatives in Bloomington came out with their addictions initiative, and we were able to get additional funding called the CARE Project. And it was piggybacked on the WeCare program, knowing that we had that high prevalence of women with substance use disorder. And so funding from that fund flow allowed us to hire addiction recovery coaches, again, peer coaches, to augment the staff of the WeCare and to get all of our existing WeCare coach expert training, so screening, brief intervention, referral for treatment training. And so that has been overlaid onto our services provided. So outcomes, main outcomes in a study like this are challenging because it takes a while to accrue the numbers. We now have over 1,000 births, so we were able to at least begin to start looking at how the WeCare on the bottom line outcomes look compared to Marion County and central regions and state. Birth numbers less than 5 are unstable, so our estimates for infant mortality rates for the white population is unstable. But African American at 6.7, again, these are early and they could vary by any season where we end up having respiratory syncytial virus. But so far, our 1,800 women served, predominantly African American, look different than Marion County's numbers and look different than the central region and even look different than the states. So our coaches are doing something here. Also, low birth weight, less than 2,500 grams, a very important outcome that also can be an indicator of risk for infant mortality within the first year of life. Again, you see we don't have cells filled in every area, but for the central region, normally 13%, ours is 11.6. So progress in important impact outcomes. We have enough numbers now to begin to look at some modeling for low birth weight. So we have close to 60 or so infants of the population born who are of low birth weight and have it by race. So we were able to provide you today, hot off the press, thanks to Beth Moser and Susan Perkins helping us with some of our modeling to show, again, these are very early and we have a lot of work to do before we're ready to publish and do the multivariate modeling. But I think some very early things that suggest there's some interesting things here going on. Normally, African American population, again, having not only higher infant mortality, but higher low birth weights. In our population, interestingly enough, the two top numbers there are Black versus Hispanic and white versus Hispanic. We don't see higher Black versus white, and I think this is because we are really working with some of the very highest risk women in our state of all races. But there is something that's called the Hispanic paradox that's seen across the United States, where women, Hispanic women with equal risk factors tend to have better outcomes. And I don't think I've seen anything that really explains that. But in our case here, the numbers of Black versus Hispanic, white versus Hispanic have odds ratios. All of these I'm showing are the significant ones, 3 times more likely to have a low birth weight. Smoking, our data confirm what has been seen before with smoke use and secondhand, certainly higher and significantly higher in the population that continues to use versus those who've had a change in behavior. Or again, none of this is all correlational. Illicit drug use, again, our population of 13 to 18% of users, we have not seen a lot of literature on this, certainly looking at community health workers and impacting use during pregnancy to impact outcomes. But again, some early indicators that using in the 12 months and since pregnant, clearly a high risk. If we can get people, even the 6% where we're reducing use during pregnancy, to potentially have an impact, especially fortified with our addiction recovery coaches. Mental health, again, this is not new as a predictor, but the fact that we were able to, impact for some people anxiety and depression scores by connecting them to services. where behavioral health is really hard to get and hard to connect to. But those who get worse still have even a worse outcome with birth weight. Food insecurity, I think, is really fascinating. We find this to be one of the topics of conversation on our weekly case conferences. That is a huge challenge. The Indiana Hunger Network group was, very, very generous in giving us the funds, food packs, emergency kits, Kroger gift cards, et cetera. So what we're seeing here is that it's not simple. It's very complex. Food insecurities are fluctuating all the time. And we can see improvement, but then the winter months come and we see worsening. And it's this roller coaster, the roller coaster of fluxing, of worrying about food or money for food, independent of even where there's improvements. It's the minimum maximums that we're seeing that are highlighting huge high-risk populations. The lack of fruit I thought was very interesting. This just happened to come up as a significant one. Again, we need to look more closely at all of this. But with our food deserts in the middle of this city, fruit is probably one of the hardest things that the individuals can get access to, at least consistently across the year for sure, even though we're connecting them to food pantries and et cetera, et cetera. There were insufficient numbers, in fact, it was 0, to show that those who had who were WIC eligible, all the babies in that group had low birth weight. So again, a very high risk indicator, and only 80%, even with best efforts, are getting connected to sign up. So that's WIC eligible, not WIC enrolled. A few other basic things that are just curiosities that those who were interested in, who weren't interested in financial planning, higher risk, those who were breastfeeding, who weren't breastfeeding at the time of the intake and during the study, higher risk. This was interesting. Those who had pack and plays versus cribs were at higher risk. We give out pack and plays to all the women who don't have a safe place for the infant to sleep. But, is having a crib, a place for a crib, a place to live where you're getting evicted and you can't be moving a crib, so you don't even want the thing, even if it were given to you. These may be different populations. Sleeping with baby despite, all the education may just be a function of complexity of babies being moved from grandma to dad, et cetera. So lots of things showing up on, early looks at univariates that we will want to delve into a lot more to understand. But I think, again, correlated to the things where we saw change and looking further into how to interpret that will be the work ahead of us. So next steps, we received some of the additional funding from the State Department of Health to create and evaluate the perinatal community health worker training program. That was one of the requests from Chris Box. So we will be doing that as part of the additional $1 million we received. We met just yesterday or the day before with the State Department of Health's new lead for the OB Navigator program, with a lot of interest in some new reimbursement schemes to community health workers that are far too low to sustain the salary lines of those community health workers. But if we can help model these models of payment for reimbursement through Medicaid dollars, that will give the sustainability in however many years it will take to do that. And then we're working right now on a IU Health Community Impact Grant that were just made available through IU Health to look at the Eastern region, which we long hoped to upscale in. And based on these numbers, you can see why John Fitzgerald and Karen Amstead very interested in the Eastern region where IU Ball is in Delaware, but they also serve Blackford and Jay counties where the numbers are low, but they have very poor access to maternal child care. And the Eastern region's numbers, as you can see, haven't budged for several years other than a 2015 blip that not sure how to explain. So again, I've taken all the time and no questions, but the team, I want to show we are a big team. It's been a fabulous group to work with, and these are the people who deserve all the credit. So thank you.